Good afternoon, viewers, and welcome to our weekly COVID update. Let me share screen. Right. Right. Today we've got a kind of a strange looking curve. As you can see over here, it's not the symmetrical curve that we had for our first wave and our second wave. Now, this is like a kind of a skewed, prolonged curve over here. Now, we don't look at these curves for their aesthetic value, but they are telling us something. And I think we need to explore what this is telling us. Remember our Gauteng curve? That's a nice symmetrical curve. It's actually, we look at this, we kind of can reflect back that we really had a massive third wave in Gauteng, more than twice what we had in the second wave or the first wave. But coming down now, not quite normal, but I'm normal, I mean back to baseline, but certainly come down quite nicely. So the Gauteng epidemic is really what drove the third wave. That was the major contributor to the third wave. Now, the reason for that skewed part of the downward part of the curve is because in the Western Cape, you can see they are still on the upswing. It's kind of zigzagging a bit, but not quite as much as the second wave, but pretty close to it, 47.1 versus 48 cases per 100,000 population. So the Western Cape is still in the throes of the third wave. And certainly we're getting feedback from our clinical colleagues that this is in fact what is happening there. Those hospitals are really being pressurized, and the shortage of beds, healthcare workers under severe pressure in the Western Cape and in other provinces as well. We look at the Eastern Cape. I've got one of the questions from one of the listeners, why do we ignore the Eastern Cape? So my apologies. This is the Eastern Cape also coming on the upswing over here and nearing what had happened in the second wave with 31 cases. We're now 25.5 in the Eastern Cape. KZN certainly on the upswing, still quite a bit below what was experienced in the second wave, but again, feedback from our clinical colleagues that again, a high pressure load on those hospitals as well. Free State also prolonged kind of curve, not coming down yet. And same with the Northern Cape. So most of the provinces, other than Gauteng and Limpopo has done very well. Those two provinces certainly come down quite markedly, but the rest in the country is still experiencing quite intense third wave activity. And that's really what caused that kind of bizarre kind of look over here, quite different to the first and second waves. Interesting enough, what I want to point out here, and I'll come back to it just now, you see the hospital admissions in the first and second waves kind of correlated pretty well with the 7-day moving average of daily cases. That was the cases and the hospitals seem to be in sync. Third wave, the hospital admissions seem to be quite a bit less than the actual notification of cases, than the daily cases themselves. Now, we're hoping, I don't want to be too dogmatic about this, but hoping that is perhaps a manifestation that the vaccine coverage is starting to have its effect. Was reducing hospital admissions, despite what I just said now about the Western Cape being pressure on the hospitals, but overall nationally, reducing somewhat hospital admissions while the cases still remain reasonably high. And that prolongation making it now a bit difficult, and I've always said that it's always difficult to predict what we're going to have in the future. So I've been often asked, when is the fourth wave going to appear? And we're trying to kind of time it to the kind of cyclical first, second, and third waves. But now with that prolongation, this might kind of put out our estimations of when the fourth wave will occur. Always unpredictable virus and an unpredictable epidemic. Just to end off the data with that solid data, the active cases coming down and starting to flatten out a bit, new cases also flattening out, and we're still getting a trickle of new cases coming into the home monitoring system, 63 cases over the 56, 63, kind of leveling out at that kind of level. Okay, let's look at the vaccines and the vaccine reach. Right, the number of total number of vaccines which have been administered, 11 million vaccines have been administered to date. And we're starting to pick up on the daily administration, 266,000, 267,000 to round it off over the last 24 hours and yesterday. So it is certainly picking up. Remember, we reached 273 when we peaked, and then it dropped down to about 150,000. Now gone back up again. But this is probably largely the result of the lowering of the age to 18 plus of people that can get vaccinated. So there is quite a bit of concern in the department about vaccine hesitancy and vaccine apathy. I think vaccine apathy we need to address by having pop-up vaccination sites in shopping malls, in taxi ranks, in places of work, at universities and schools and so on. I think that's got to, because there's probably a large percentage of individuals who just have not bothered, or it's difficult transportation-wise to get to a vaccination site. In terms of the vaccine hesitancy, again, we need to kind of have a greater concentration on communication at a community level, the so-called trusted communicators. But hopefully we are going to reach our target of 300,000, which we aim to get by the end of this month, which is what's coming up now, the end of the week. Well, let's look at the vaccine distribution. These 11 million doses, 2.5 million of the single dose Johnson & Johnson, 8.5 million, just under 6 million of the first dose for Pfizer, 2.6 million for the second dose of Pfizer. How does that translate in terms of coverage? Well, we are creeping up. Fully vaccinated, that's the one dose of Johnson & Johnson and the 2 doses of Pfizer, 13% of the adult population have been covered, being fully vaccinated, and 15% being covered with the first dose of Pfizer. The total number of individuals who've been vaccinated, 8.439 million. That's just over 21% of the adult population, or 14% of the total population. So still got a way to go until we're going to get a reasonable amount of population vaccination. Still got this uncanny distribution of male and female, the females being at least 50% higher than males. And in fact, this has been shown in all the age groups, and worryingly in the 60 plus age groups, the target age group. Why this is a complete puzzle, but it still seems to be persisting. All right, now I want to deal with something which quite a few people have asked me about, and that is the vaccines working? Or, there's a lot of kind of hype about the rise in cases in countries which have achieved high vaccination coverage. And let's start off with Israel. Now, this is just barely 3 months ago when the then Prime Minister Netanyahu claimed that they had conquered COVID and they can now go completely back to the pre-COVID era and do away with all the restrictions and the preventative measures. And in fact, Israel, if you look at these headlines, Israel, a worldly in the New York Times, and fighting the virus, grapples with a new outbreak. The first to vaccinate and the first to party, Israel now mulls lockdowns. So they reached 2/3 of the population being vaccinated with Pfizer or Moderna, with the 2 mRNA vaccines, and yet they had this steep increase. And in fact, Israel now is nearing to 10,000 new cases per day, which is what they had in the pre-vaccination era. This goes all the way back to January when they started the vaccination program. And this is reflected both in the daily cases, reflected in admissions to hospitals, and reflected in deaths as well as increase. Okay, the deaths very much less. I'll come to that just now. But certainly the new cases are quite a sharp increase despite this high vaccination coverage. It actually mimics what happened in a few other countries. Okay, this is a small country, Seychelles, but they in fact had a vaccination coverage even higher than Israel. They were in the mid 70% of their population being covered with vaccination. And then they had this major upswing of cases. In fact, at one stage in this, they were actually the world leaders in vaccine coverage, paradoxically, and also in number of daily cases. If we come to the United States, this comes from the Center for Infectious Disease Research and Policy, CIDRAP, which is a very reputable monitoring organization. And as a headline, United States cases back to pre-vaccination levels, 900,000 over this last week, 140,000 per day. And Florida, more than 30,000 cases per day, much higher even than in the pre-vaccination era. So what's actually going on? Let me just look at the vaccine effectiveness. And I'll look at the USA data, Pfizer or Moderna, they're pretty much the same vaccines, 2 doses. Now, pre-Delta, these are average figures. And if you read various data, they might be a bit higher, some might be a bit lower, but it's sort of an aggregate figure for efficacy, preventing infection, 55%, preventing symptomatic illness, in other words, mild or moderate illness, 80%, preventing severe illness and hospitalization, 90%. That's in the pre-Delta era. Now, when we come to the Delta era, this drops quite substantially. In other words, the Delta virus, the one that we know is a real worry because its infectivity, its contagiousness is significantly higher than its predecessor variants. And the effect of vaccine in preventing infection is considerably low, 39%. Symptomatic illness from 80% down to 40.5%. However, preventing severe disease, hospitalization, and severe disease itself, pretty much no difference. And I think that's really the key. And this is a well-known diagram. Many people I've presented before, and others have also presented. If we look at the United Kingdom and their second wave, these are the cases per 100,000 population as the second wave matured. And as these cases increased, so did the deaths, the ultimate measure of severity per 10 million population, increased at the same rate, more or less. Then when we come to the third wave where in the United Kingdom had a high vaccine coverage, although the case numbers increased pretty much on the same kind of level on the second wave, but the severity was markedly reduced. The deaths per 10 million, you can see very much less. Still there, but the great majority, the vast majority of these in people that weren't vaccinated. So if we look at what are the goals of vaccination, we are now in stage A. The goal of the vaccination at this stage is individual protection. In other words, it's vastly lowering the rate of severe disease, hospitalization, and mortality. However, it is not at this stage protecting the population in the sense that the virus is still circulating substantially to the population. And even with high levels of vaccine coverage, it's not, particularly with the Delta variant, not substantially reducing the circulation of the virus, in other words, reducing infection and reducing mild disease. So vaccination extremely important. We do need to lower the load on the hospitals. We do need to prevent severe infection, and we do need to reduce mortality. So I'll leave it there and now go on to some of the questions. And again, thank you very much for questions which have been submitted to me. One thing, I've had a number of questions, a large number of questions about booster doses. Now, the Johnson & Johnson vaccine is a 1-dose vaccine, and that gives good immunity. It's been shown in a number of trials, including in South Africa, to give robust, durable immunity right up to, in fact, up to 280 days, which is now, 9 months, good immunity. Pfizer, the 2 doses, similarly. I think what has been happening that people are picking up what I've just mentioned now, the mild cases, or what we call breakthroughs, in other words, people that are getting the infection in a mild or moderate way, despite being vaccinated. I must also just point out that no vaccine is perfect. And even there is breakthrough infections which can be severe. People that have been vaccinated, the great majority of these people who do have severe comorbidities. But again, let me stress, preventing mild and severe disease. So where are boosters being looked at? Well, the one group are the healthcare workers for two reasons. One of them is that they were the first to be vaccinated with the Johnson & Johnson between 6 and 8 months ago. So the question is the immunity starting to wane now? And I've had many questions about this. Well, the data doesn't seem to support that. However, we are still looking at just empirically giving a booster dose, but there's been no decision, I emphasize, no decision as yet. That's the one group. The one group where there's no doubt, and those are the immunosuppressed individuals, people whose immunity is suppressed with drugs. We look at, for example, people who have been organ transplant recipients, people with various malignancies. There are two reasons for giving them a booster. One is the obvious one, because their immunity, they haven't responded so well to the initial doses, and we want to boost their immunity. But also those are the people that may generate variants. Because their immunity is a bit lower, the virus is replicating, and it'll select for, while it's still replicating, those variants, those mutations where these mutants have a selective advantage and can escape immunity. So in that group, there is certainly a main indication for a booster dose. In that group, also looking perhaps, and there's a big question mark, the elderly individuals, people over the age of 65, who again have not perhaps responded as well as younger individuals. So these are the possibilities for boosters. I said the immunosuppressed is one which was a probability. The healthcare workers, the elderly, and the rest of the population, it's still being investigated whether boosters are in fact necessary and will be administered. I think our main aim at this stage is to get as many people immunized as possible, as quickly as possible, with the vaccine that we have got available. All right. Now, another question which you've sent in, are people that have been vaccinated less infectious? I've tried to point it out, yes, there are. People that have been vaccinated are less infectious, but are not totally non-infectious. In other words, they still can pass the virus on. And this is why, in fact, we've seen in Israel, in the United States, in European countries, despite high vaccine coverage, people that are vaccinated may not have any illness, and may have reduced, and sometimes even substantially reduced, ability to transmit the infection, but they are still transmitting the infection, and the virus is still circulating. And this is why it is so important that people that are vaccinated still take all the precautions until we can get to a stage where we stop that virus or limited the virus circulating in the population. Then on a different tack, I've got a question about somebody that, and there were actually one or two questions, who at the vaccination site, they get an itchy rash. Now, there are a number of questions about allergies. People that have allergies to food allergies, bee sting allergies, penicillin allergies. Is it safe for them to get the vaccine? Yes, it is. The vaccine itself really is pretty innocuous. It contains the vaccine thing, which is in the messenger RNA in the case of the Pfizer thing I spoke about before. That's enclosed in the lipid nanoparticle, minuscule particle, to protect it. It's got a stabilizer called PEG, polyethylene glycol. And that, in a very, very few number of people do have an allergy to that. And they can, and I've said it in a number of previous occasions, very rare situation of getting an allergy to PEG. And that may be severe. We've had several cases of anaphylaxis, severe allergic response. Only very few in this country. Most of that have been reported in the States. It's a few per million doses, allergy to the PEG. The rest of the Pfizer vaccine really contains very innocuous material. Inorganic salts like potassium chloride, potassium phosphate, sodium chloride. There's no way one can be allergic to these those things. With regard to the Johnson & Johnson vaccine, again, it's just got the adenovirus vector, and then also just various stabilizers, very innocuous stabilizers, polysorbate and dextrin and citric acid, the sodium chloride. There's no iodine, there's no sulfur, there's no antibiotics in either of these vaccines. So people that do have allergies, we do advise caution, stay a little bit longer after your vaccine, take a good book, stay for 30 minutes instead of 15 minutes, but really having allergies is not really a reason not to get the vaccine. I'll just round off with a question from a listener about the hand sanitizer, something a little bit different to the vaccines this time. The alcohol-based sanitizers are very effective. This virus is very sensitive to, in fact, all antiseptics, detergents, ordinary household soap, and certainly alcohol. This question has asked about using hypochlorous acid and chlorine. Those are harmful to the skin, and they're really not necessary. The ordinary alcohol sanitizers are very effective in inactivating the virus. So thank you very much for listening, and welcome again next week to our midweek COVID update. Thank you very much.